This is ReachMD, and I'm Dr. Jennifer Caudle, host of Everyday Family Medicine. And with me today is Dr. Jeanine Downie, board-certified dermatologist instated by the American Board of Dermatology. She holds medical licenses in several states, including New York, New Jersey, and California. She's also the director of Image Dermatology, her own practice located in Montclair, New Jersey. Dr. Downie has extensive experience and training in cosmetic, laser, and general and surgical dermatology. Dr. Downie, welcome to ReachMD.
Hey there, how are you, Dr. Caudle?
I'm good, thanks. So today we're actually talking a little bit about your path in dermatology, but we're also talking about when physicians should be referring patients to dermatologists and also hot topics for this year. So if you could maybe start by telling us a little bit about your practice, why you chose dermatology, and maybe the areas of dermatology that you specialize in.
Okay, so in terms of my practice, I practiced about 12 miles outside of Manhattan in northern New Jersey. I see probably about 65 or so percent, if not a little more, cosmetic patients, about 70% women, 20% men, and 10% kids and teenagers. I see about 60% Caucasian American patients, and then about 40% African American, Latino American, and Asian American patients in that order. Within my practice realm, I also travel a lot because I do clinical trials. So I get a lot of cutting-edge information on, like the new Kybella that hopefully we'll talk about later in this radio broadcast, because I did the clinical trials on it. A lot of the new and cutting-edge toxins that are coming out and fillers, different filler indications, all that fun stuff. So I'm traveling a lot to investigator meetings and to accommodate things for my clinical trials. And then I do a lot of consulting for the top-tier pharmaceutical companies. So for Allergan and Johnson & Johnson and Galderma and some of the bigger dermatologic top-tier pharmaceutical companies, I do a lot of consulting with them. So I do that as well. I lecture nationally and internationally on cosmeceuticals and skin of color and skin cancer and toxins and fillers. And my favorite topic lately is non-invasive fat melting. As I get older, I'm more obsessed with my own body fat percentages, which unfortunately seem like they're going up. And so I'm concerned about getting everyone's down. So that's some of the stuff I do besides the fact that I'm a wife and a mother.
Where should we start in terms of some common or uncommon things that primary care physicians should be on the lookout for and we should refer to our dermatologist for?
Okay, that's a great place to start, I think. So basically, Dr. Caudle, what I think is really important is when family practice and internal medicine doctors or OBGYNs or pediatricians see lesions that they're the least bit concerned about, it's worth calling a dermatologist and getting a referral and having the patient go within a week. There's many of my colleagues in town and around the area that I would not think about saying, oh, no, I'm overbooked. I couldn't possibly squeeze in your patient for that one suspicious mole. It's not reasonable. Last year, according to the Skin Cancer Foundation, there were, roughly about, we haven't finished the tallies, but 4.2 million cases diagnosed in 2014. So that number is going to go up probably to 4.5 million new cases of skin cancer diagnosed in 2015. That's frightening. So PCPs and all docs should just refer to us if they see a lesion that they're concerned about that warrants a biopsy. The issue is sometimes my friends will try to biopsy those lesions themselves, and then they send them to pathologists that are typically surgical pathologists and don't do a lot of reading of the skin, and the lesions can get misread, and that is a huge problem, especially if they're an impending melanoma. Where I practice here in New Jersey, unfortunately, is the tanning bed capital of the United States. So every time you walk into a tanning bed, you're increasing your chances of getting skin cancer, a very significant amount. And it's really upsetting to people when they're misdiagnosed because they had a biopsy and then it wasn't read right. So I just say send them to us to begin with. We'll look at it. If it's a changing mole, if it's a new lesion, if it's something that anybody's the least bit concerned about, it's worth getting an opinion from a board-certified dermatologist, don't you think?
You bring up some really good points there, and I think sometimes points that maybe we as primary care doctors don't think about. I'm really curious. What are some other things that you as a dermatologist maybe see us PCPs send you that you're like, maybe they should have thought about this or tried this first, or, any common things, anything with, I don't know, eczema, psoriasis, or other conditions that may be mismanaged or not managed well?
I get referred a decent amount of psoriasis, eczema, hives, that type of thing. But in many of those cases, the primary care physicians around here, they all think about, what they're doing before they refer. So I don't feel like I get cases that, oh, my goodness, I should have definitely never seen this. I don't feel like that at all. They're my colleagues, and they're busy. And quite frankly, when somebody comes in here and they ask me questions about their blood pressure pills or their heart or their diabetes, it's not that I don't have the time for that. It's that I'm not properly trained for that.
Sure.
So I will send out in a heartbeat. So I'm never feeling like, oh, they should have tried X, Y, and Z first. I mean, my main thing is if they have a bad rash, the patient, and it's a Friday afternoon, and perhaps they can't get in to see a dermatologist until the following week, definitely make them cut their nails off. Tell the patients that they don't have weapons, they won't go to war.
Oh, that's actually a really good idea.
Have them cut
that.
their nails off and have them get a hypoallergenic, fragrance-free moisturizer to moisturize their skin during the course of the weekend, and maybe take Claritin or Benadryl until they can get in if they have some rash where they can't be seen right away. So those are the type of things that sometimes I wish people had tried before they wait a week or two to come see me, and they saw the pediatrician or the family practice doctor when things were looking one way, and then by the time they see me, it's 10 times worse because no one told them to cut their nails off or maybe take a Claritin or Zyrtec to avoid the itch, or maybe told them to use some kind of non-scented moisturizer, that type of thing.
Absolutely. No, I think that's actually a really great idea, and it's something that I definitely going to start actually asking my patients to do. I like that phrase of cutting the nails off because you're right, it makes a big difference.
Patients need to hear things several times from several different doctors before they enact on a plan. So it would be good if you guys would do that also.
Absolutely. No, I think this is really good. Do you, any other tricks up your sleeve? I like these sort of suggestions. This is really good.
Well, the old classic, humor, oh, doc, it hurts if I go like that, and the patient's banging on the side of their head, and then you say to them, well, don't go like that. Don't bang on the side of your head. So if the patient's saying, it hurts when I press down really hard on, this one area, well, don't press down on that area. It could be a lipoma, which is a fatty tissue tumor. It could be a cyst. It could be, something else, but let's not press down on that. Let's actually, one morning, one of my patients the other week came running over here to see me from her OBGYN, and the OBGYN had circled what she wanted me to biopsy. And I just thought it was the best. We're busy. It's right before Christmas. She didn't think she was going to get me on the phone, so she just circled it, and she called ahead and sent her over here, and I was able to biopsy, and it turned out that it was a cyst and not, something more dangerous than a cyst. But the fact is, she circled it for me, and I just felt there was such camaraderie in that spirit. You know what I'm saying?
I think that's a really good point. If you're just tuning in, you are listening to Everyday Family Medicine on ReachMD. I'm your host, Dr. Jennifer Caudle, and I'm speaking with Dr. Jeanine Downie, board-certified dermatologist and director of Image Dermatology, her own practice located in Montclair, New Jersey. So, Dr. Downie, I'd like for us to continue talking a little bit about some of the latest and greatest with cosmetic stuff. You mentioned Kybella. Can you tell us a little bit about that?
So, Kybella was FDA approved in, what was that? I believe it was April or May of 2015. And they started rolling it out as of July 2015. So it is a very interesting new injectable drug that we inject under the chin, and it melts fat from under the chin and really can make people look years younger. And a lot of people, the collection of fat that kind of, comes to being after a certain age is very difficult to get rid of, even if you're at your goal weight, which unfortunately many people over the age of 40 are not at their goal weight any longer. But even if people lose weight, they might not lose it from that area. So this really helps with the whole jawline for men, in terms of making them look more youthful. It helps with women so we don't have pooch under our chins, so it helps us look more youthful. And it's just a really interesting injectable drug. We are specifically trained how to do this. So I did the clinical trials for this back in 2012 and was raring to go because I realized how well in my patients, it was a double-blinded study, but I could tell which of my patients were doing, better because some of the fat was going away in some of them. So it's a pretty neat drug. It's very specific, and it's about injecting it properly and making sure you mark off the nerves and making sure that you explain to the patient that they're going to have swelling, they're going to have some bruising, and then the fat is going to be down, and people are delighted by that. And so in this day and age, I try to explain to patients that it's not really about, just romantic viability, looking good for your husband, wife, girlfriend, boyfriend, whomever. It's about, economic viability. It's about, not wanting to be the old guy or the old gal on the job and kind of maintaining, your edge in the work world as well because, unfortunately these days this is a society that looks at everything, including the age of the people that are working in the workforce. And nobody wants to be old anymore, and part of the poochy chin makes you look a little older than you want to for many people. I'll say myself included.
That's so interesting. Now, are there certain patients that you would not use this in? Who would those patients be?
Yeah, the very, very overweight patients that need to generally lose, weight rather than the patients that just have a pocket of fat there. But even in some patients that are somewhat overweight, it still is a good drug. And many of my patients feel like now that their chin fat is down some, or their chin fullness, as I like to say, is down some, they feel like it's spurring them to start losing more weight because they feel like their jawline profile is looking better. So they're like, oh, I don't want to mess this up, so let me start, dieting and exercising properly. So that's, kind of neat and rewarding for me to see with a lot of my patients.
Right, so it's
patients
good motivation.
That have very lax skin, that have very, very loose skin, either very, very sun-damaged or, much older patients, because this drug is used to patients well into their 70s as long as they don't have very lax skin. But if patients have lax skin, smoking, tanning, yo-yo weight gain and loss, that type of thing, and they have very lax skin, then this isn't a good drug for them as well. But again, send to the dermatologist, let the dermatologist take a look and judge. It has to be somebody who is trained on Kybella or somebody like me that, did the clinical trials and teaches other physicians good practices with Kybella, that type of thing. So we look at those two things. If you're very, very, very overweight or you have poor skin laxity, then, you're not a good subject. But otherwise, you probably could be.
Right. And I don't know if you mentioned this, but how long does it take to see results with this, by the way?
Typically, people come once a month for either 4 or 6 months.
Okay.
And then the fat is gone for good.
So it's permanent?
A liposuction-like result.
Oh, my gosh.
Permanent. Yeah, so it's a permanent result. So that's what's so fabulous about it.
That is amazing.
People's lives are altered for the better. People have been really excited by this drug.
So
I'm very excited by the technology.
Are they planning on using this molecule for other parts of the body then? That's my next question.
Potentially. I don't know about any clinical trials right now. Allergan, now Activist, and now Pfizer just bought them, owns the molecule. So not that I know of at present, but I don't see why not in larger areas with a lot of fat cells in them. This wouldn't be a good drug for larger areas, too. It's not a cheap drug, is the bottom line. So, we'll have to see.
Sure. And I think we have time maybe for just one last small kind of touch-in. I just wanted to ask in terms of other cosmetic procedures that you're doing, that you're seeing, that you've been involved in trials with, are there any other procedures or techniques that are kind of sort of the latest and greatest? Are there any other things that you're sort of a fan of that people are getting and that you're performing? Just out of curiosity.
I think that Botox is still a huge standard. I mean, the bottom line is Botox is like breathing for me and a lot of my patients. If you can afford it, it's something that you should schedule in and do just because if you don't crease the envelope, you'll never have a deep crack or a furrow or a line there like your mother or your grandmother or your father, whoever you're trying not to look like, has. And, the bottom line is that it's not about like having a stiff forehead and looking like a board anymore. It's about having a movable, bouncy forehead that just doesn't have a lot of lines in it, so you don't look stressed and you don't look worried. And so people really like that they're, showing, not showing their their true feelings, and that they can kind of be, a little more calm when they're not feeling calm at all. So I think Botox is, huge, and the bottom line is it's best to go to somebody that has a lot of experience. I've been injecting Botox for, 22 years now. Oh my God, am I saying that? So 20 years on myself and 22 years on my patients. And I've been doing fillers since 1994 as well, so that would be 22 years with fillers. And I was involved in the original Restylane and Perlane clinical trials and the Belotero clinical trials. And a lot of these fillers are fabulous when used properly, and a lot of people are afraid about looking fake. But the bottom line is I tell people that, diet and exercise is super important, but as you get older, Botox, filler, laser, and a lot of these other things, Kybella, are important as well. And as long as things aren't overdone, one can look very, very good.
No, I completely understand that. I have sort of one last follow-up question that's kind of a personal question as it relates to that. Some of my good girlfriends are, cosmetic surgeons, et cetera. And one of my girlfriends actually said it's best to get Botox when you're young. Is that something that you feel? Is it something that you...
I see a huge trend with that, where people are coming in that are like 26 to 31.
Right.
Well, I have a whisper of a line here, and I don't want this getting any deeper, and we just do baby Botox on them, where we do a little bit of Botox, and they're very happy, and maybe they're coming twice a year rather than every 3 months. And the bottom line is then their skin is increasing in those areas, and they're very happy with that. And in addition, young or old, the bottom line is that people need a good skincare regimen, and that includes sunblock every day with an SPF 30. Rain or shine, January through December, regardless of what your ethnicity is. So I tell people, I'll definitely Botox you, I'll definitely fill you, but you need to put on your sunblock and you need to reapply it, or we're wasting our time. And my patients are usually in agreement with me because they don't want to waste their time or their money.
Right. No, that makes a lot of sense. Well, this has been a really interesting conversation. It's nice to talk about some of the latest and greatest, especially with dermatology. Before we close, is there any other topics that you wanted to touch on today before we end our interview?
I think it's really important for people to realize, back to skin cancer for a second, that they should look at their body at least once a month, and if they see something changing or not healing, they need to call and make an appointment with the dermatologist themselves, and that everyone should get a total body check at least once a year. And people need to take responsibility for putting on sunblock and reapplying it. On the cosmetic side of things, I'll tell people my practice is Image Dermatology in Montclair, New Jersey, and I make people look their best for whatever age they are. So I consider it age management. So people don't have to look done. So all these patients that are coming into you, Dr. Caudle, and saying, they don't want to look done, tell them they don't have to. They shouldn't go to somebody who is done. That way they won't look done.
I think that's very inspiring advice to close the interview on. Dr. Downie, many thanks to you for joining us on ReachMD today.
Thank you very, very much for having me, and I look forward to hopefully being on in the not-too-distant future.
Absolutely. I'm your host, Dr. Jennifer Caudle, and you've been listening to ReachMD. To download this podcast and others in the series, please visit us at reachmd.com/everydayfamilymedicine. Thank you for listening.